I'd like to invite our second speaker, Dr. Indumati Joy, Madam, Senior Consultant in Nova Fertility Center, Chennai. A short synopsis about Madam's profile. Madam has graduated from MBBS from Kilpak Medical College, DGO from Stanley Medical College, Chennai, DNB from Sundaram Medical Foundation, Chennai, Fellowship in Reproductive Medicine from Madras Medical Mission Hospital, Chennai. Madam has experience in the field of obstetrics for 25 years and in reproductive medicine for more than 15 years. She is the executive member of Indian Fertility Society, Tamil Nadu chapter. She has authored and co-authored several papers in journals pertaining to reproductive medicine and andrology. Madam's areas of interest include minimal stimulation protocols in IVF and gynec endoscopy. Over to Madam.
Good morning to one and all. I would like to thank first Professor Dr. Meera for giving me an opportunity. And also I'd like to acknowledge that Dr. Ratna Manjushri, the Vice Principal of this college, is my classmate. We both studied together here. We belong to the 89 batch, and I'm so proud to have her here for the little talk I'm going to give. And so I'm going to, can you start the slide? So I'm going to talk on pre-implantation genetic testing. So we are all here to know more about prenatal diagnosis. Prenatal So a prenatal diagnosis is a science of identifying the structural and the functional abnormalities in the developing fetus. So the diagnostic evaluation of any couple on whom we are going to evaluate typically involves three major categories. So what are we going to study? We are going to study the fetuses at a higher risk for a genetic or a congenital disorder, or fetuses at high risk for common congenital abnormalities, fetuses discovered ultrasonographically to have structural or functional abnormalities. High risk describes a risk greater than the chance of fetal death associated with diagnostic procedure considered. So congenital defects may be anatomical or functional. Causes of these defects may be preconceptional or because of post-conceptional exposure. So the defects which we usually look for is the chromosomal abnormalities, single gene defects, multifactorial and unknown causes, and anomalies due to exposure of teratogens. So what are the indications for a prenatal diagnosis? If we suspect an increased risk for fetal chromosomal abnormalities based on advanced maternal age, previous pregnancy affected by fetal chromosomal abnormality, family history of known genetic condition, or if a couple is known carrier of gene mutation. Either of the couple affected by congenital disorder, example, congenital cardiac defects. Or if there is a family history of congenital abnormalities, maternal medical condition like diabetes, autoimmune diseases, hypertension, hypothyroidism, etc. Abnormal ultrasound findings, medications like anticonvulsants, oral anticoagulants, chemotherapeutic agents, congenital infections like rubella, CMV, chickenpox, and syphilis. So my topic today is PGD, prenatal genetic diagnosis. It is a part of prenatal diagnostics. So So PGD is the state-of-the-art procedure used in conjunction with IVF, in which the embryo is tested for certain conditions prior to being placed in the uterus of a woman. So PGD was first reported in 1990, and PGD combines the recent advances in molecular genetics and in assisted reproductive technology. Worldwide, more than 1 lakh babies have been born because of PGD. And then the process of going through a PGD involves first is you have the accurate genetic diagnosis and then appropriate genetic counseling. And then the couple actually visit an IVF center where we do the embryo biopsy, and then we do the diagnosis by FISH or PCR. And then once we know that the embryos are safe, that is, we have done the FISH and PCR and we have detected the particular anomaly which we were looking for, then we transfer around 1 to 2 unaffected embryos. So this is okay. So ovarian stimulation is the first step where we do, and then we retrieve the oocytes, and then this is done under ultrasound guidance. And sperm preparation, whichever preparation, the density gradient or testicular biopsy, and then we do ICSI, intracytoplasmic sperm injection. And then we observe the embryos in the early cleavage stage, where they go from the 2nd day to the 3rd day and then to the final blastocyst stage. So how is PGD performed? PGD is performed from after the stimulation. It is done on the day 3, where it is called as a blastomere biopsy. And then we do the day 5, where it is called the trophectodome biopsy. And we do the genetic analysis and transfer the unaffected embryo. So there are 3 types of PGDs that are performed. That is from the polar body biopsy, cleavage stage, or the blastocyst biopsy. In a polar body biopsy, we take only the polar body from the oocyte and we examine. So this does not provide the diagnosis of the paternal alleles and the gender of the embryo. In blastomere biopsy, we remove 1 or 2 blastocyst cells and we do the examination. So in the trophectoderm also, trophectoderm is the outer layer where you have the inner cell mass inside and it is surrounded by the trophectoderm. So we can do the trophectoderm biopsy also. And then we do the genetic analysis by polymerase chain reaction or FISH or CGH24, DNA microarrays and NGS. So we have the rest of the speakers for going to talk more on these methods of analysis. So the most important thing which we are all worried about this is the history of trisomy 21. So when a couple come to us with the trisomy 21, with the first child affected, so we are quite concerned that the second baby that is to be born should not have this. So what we do is we do the IVF and we take it to the blastocyst culture, and then we do the biopsy, make sure that the trisomy is ruled out, and we implant only the normal embryo. So the indications for which we do PGD is the chromosomal rearrangements, inversions, translocations, and chromosome deletions. So first of all, when a couple come to us with an affected child, we send them for genetic counseling. And then the genetic counselors usually counsel about the probable defects that the baby can have if they don't undergo this procedure. And gender determination for severe X-linked disease. So gender determination is prohibited according to the PNDT Act in India. So the only condition where we do the gender determination is when you have an affected girl child or a boy child in the family. After that, we do PGD for severe monogenic diseases like cystic fibrosis, beta thalassemia, sickle cell anemia, Fragile X syndrome, recurrent pregnancy loss, or an advanced maternal age. Advanced maternal age is anywhere between 38 to 45 years. And couple with more than 3 IVF failures, epididymal or testicular sperm aspiration with more than 1 IVF failure. So men who undergo testicular biopsy for azoospermia also can have more DNA damaged sperms. So for them also we do PGD. Unexplained infertility and Y chromosome deletion found in 5 to 20% of the men with low sperm count, or couple who have previously had a pregnancy with a chromosomal abnormality, or where one partner carries a balanced chromosomal translocation. So if we are suspecting chromosomal defects in the couple, we have to do karyotyping for both of them and decide what exactly we are going to look for in the embryo. So this is a list of disorders, single gene defects, which could be the possible cause of an abnormal baby. So a genetic counselor will counsel about the probable conditions that can happen. And when we send the embryo for testing, they test for all these conditions. And PGD indications also, here also there is a big list, which usually the genetics people will be deciding, and they will be doing all these tests to rule out these conditions in the fetus. So what is the benefit of this PGD? So there is an increased implantation rate that has been observed, and this reduction in the pregnancy loss. We all know that an abnormal baby will usually result in a miscarriage. So we can reduce the miscarriage rates if we know that it is a normal baby. Reduction in the chance of having a child with an aneuploidy reduces the possibility of having to choose to terminate the pregnancy following a diagnosis of a probable genetic disorder. And benefits of PGD, it also helps in avoiding the birth of another child with a genetic disorder. Invasive diagnostic procedures, which include chorionic villus sampling and amniocentesis, can be avoided if we know the defects at the embryonic stage itself. Possibility of an established pregnancy termination, and risk of miscarriage due to genetic disorders, risk of future fertility problems. So what are the risks of this PGD, which has been canvassed so much? Even if we do very carefully the biopsy of the embryo, the trophectoderm or the blastocyst, there can be chances of embryo damage. The oocyte and the embryo biopsy are invasive procedures. And then sometimes there can be misdiagnosis also. The accuracy of a PGD for the translocation is around 90%, which means that there is still a 10% chance of having a misdiagnosis. There's also a possibility of false negative result, false positive, and the chance for no result. Like it is like how we give sometimes the material for histopathology, and sometimes it's inadequate or not good enough. So the same result can happen for an embryo biopsy also. And the chance for mosaicism. And for any woman to have her embryos tested, she has to undergo the risks of IVF. Without doing IVF, there is no way we can do an embryo biopsy. So hyperstimulation, multiple pregnancy also is the known complication of IVF. So use of special precautions to avoid exogenous DNA. Extreme precautions need to be taken to avoid mix-up of the samples and also the exogenous DNA. Contamination has dramatically reduced the main causes of misdiagnosis. So the risks in PGD again is not achieving a pregnancy. So we have tested the embryos. We have ruled out the possibility of that the embryos might be normal, but still the implantation does not happen even if we put normal embryos into the uterus. There may not be any normal embryos available for the transfer. So for example, if we send 10 embryos for testing for abnormalities, all the 10 may not have the abnormality. Maybe 2 will be normal out of that. So all the 8 embryos will be wasted. So there may not be any embryos for the next transfer, and she will have to undergo the IVF cycle all over again. The embryos may not implant and develop even if they do not have the defect. The workup for PGD is quite expensive and labor intensive. PGD can only detect a specific genetic disease in an embryo. It cannot detect many genetic disorders at a time and cannot guarantee that the fetus will not have an unrelated birth defect. So this is very important in counseling, because everyone thinks that if you do the PGD and if you transfer a normal embryo, it will result in a normal baby. It is not always like that. So what is the future of PGD? So efforts are continuing to be focused on improving the methods to obtain an accurate diagnosis, which is very important. PGD holds great promise for the future as techniques and genetic tests have perfected. It may become a routine test in the next few years because of the advancing age when women want to become pregnant. So usually when the woman is more than 35 years, the chromosome abnormalities are much more than when a 23 to a 27-year-old delivers. So we all know this. So as the reproductive age is advancing, this might become a routine in the next few years. So with the advent of the microarray techniques for the analysis of the genome, transcripts of thousands of genes can be tested at one time, and the combination of both might dramatically change our future. To conclude, PGD is a reliable procedure in presenting the birth of an affected children. PGD of aneuploidy is effective and results in a high take-home baby rate when implanted in certain category of patients. Despite the efficiency of the PGD technique, conventional prenatal diagnosis is still required by most PGD labs. PGD for aneuploidy is a valuable and an effective tool for increasing the ART outcome and decreasing the rate of abortions in case of advanced maternal age and severe male factor infertility. The development of PGD is one of the most exciting and important milestones in the history of assisted reproductive technology. Thank you very much.
Thank you, madam. Now we would like to invite our next speaker, Dr. Aishwarya Parthasarathi, madam. Here is a short synopsis on her profile. Madam has graduated from Government Kilpak Medical College, post-graduation from the prestigious All India Institute of Medical Sciences, AIIMS, New Delhi. Worked as a senior resident in OBG at JIPMER, Pondicherry. Fellowship in reproductive medicine from Madras Medical Mission, Chennai. MRCOG from UK. And she has won several prizes in various conferences and she has published 4 international papers. Madam's field of interest include reproductive medicine and gynecological endoscopy, patient and payer group education on various social media platforms. Over to madam. No problem.
Good morning, everyone. At this outset, I'm very happy to be in the place where I did my undergraduation. I would like to thank my professor, Dr. Meera ma'am, who is like my mother. She has given me this opportunity. I was a classmate of her son, Dr. Gautam. So we are still friends. It is very happy moment that actually my 2 of my teachers are here. One Meera ma'am from undergraduation, another fellowship teacher, Dr. Indumati Joy. It gives me immense pleasure to follow her talk. This is the first time I'm doing this. I feel very blessed to be in this stage. Thank you so much, ma'am. So today, I'm going to talk on genetics in OG practice, common scenarios and practical perspectives. These are some of the cases which we have done in our fertility center, A4 Fertility Center, what has happened and what we did for such patients. So, introduction, knowledge of human genetics has increased dramatically as obstetricians, gynecologists, and other healthcare providers are increasingly called on to incorporate genetics and genetic testing into medical practice. And counseling is the key. So, genetics is still a gray field, and we are still not knowing what is, what exactly we have to tell the patients. So what are the dilemmas of a gynecologist when we are going for a genetics? First, where to refer, whom to refer? That is the first dilemma. And second is the cost. cost of the treatment, especially the genetics testing itself is very expensive. That is also another dilemma of a gynecologist. So the number one case which I'm going to present is Mrs. A 33-year-old lady. She had a previous full-term normal delivery and she's now second gravida. She has a healthy baby boy and she's on a routine antenatal care pathway. She had an NT scan which showed absent nasal bone and NT which was 1.5 mm, which is actually normal at 12 weeks and 3 days of gestation. So what next? Because of an absent nasal bone, what are we going to do next? That is the question. So according to the Fetal Medicine Foundation, what we have to do is the scan should be repeated in 1 week time if there is an absent nasal bone, and we have to rule out for the trisomies. So what are the biochemical markers which we advise at a NT scan? That is the combined screening. A dual marker plus an NT scan is almost 95% sensitive, which we advise for all women undergoing the procedure, for all antenatal women, does not depend on the age. So we have to understand that nasal bone is absent in 1 to 3% of the cases normally, but the babies which have an absent nasal bone have an increased risk of chromosomal abnormality, and they should be evaluated for chromosomal abnormalities. So we have to discuss with the lady to give an option of the regular dual marker or a non-invasive prenatal genetic screening, which Meera ma'am will be talking in the next talk. So this is called a cell-free fetal DNA. Only then we have to give them the option of amniocentesis, as the cell-free fetal DNA itself is 99% sensitive. So this is the algorithm. If you have an absent nasal bone and no other soft markers, first advise the patient a dual marker. So a combined screening test itself can diagnose any condition 95% of the case. If the patient is affordable, offer them an NIPT or a cell-free fetal DNA. Or if you think there is other markers, or if the patient is very anxious and wants to know 100%, go for an amniocentesis. And NIPT, if normal, there is no need for further invasive testing. So do not scare the patient telling that absent nasal bone is a big thing, because it can grow in future also. So we gave her the option of NIPT and the baby was normal. So what is NIPT? DNA fragments are found in the pregnant women's plasma. Both mother and fetus DNA are found, and sequencing analysis are used to analyze the cell-free fetal DNA and specific chromosome or genetic condition. If it is there, then the levels of the particular cell-free DNA is increased. This is cell-free fetal DNA testing. NIPT is usually arranged after 10 weeks of gestation because the fetal fraction is higher. So the disorders which are there are Down syndrome, Edwards-Patau's 6 chromosome aneuploidies, and Dijorda's syndrome, which are usually detected by this NIPT. Not all the problems can be detected. These are the usual, and it has the best sensitivity for a Down syndrome, Edwards and Patau's syndromes, almost more than 99%. So case number 2. So she was a second gravida para-1 living on 30 years old lady who came to me with, she had a non-consanguineous marriage. A 5-year-old son had microophthalmia, coloboma, and delayed milestone. Very surprisingly, for the 5 years, only pediatric evaluation and speech therapy was done. No genetic evaluation was done. She was already pregnant when she came to me. So what we did is, we advised her the karyotyping of both parents, and the index child whole genomic exome sequencing and microarray analysis was actually done. So the result was that there was a large deletion in chromosome 18, which was pathogenic, and it was identified by the microarray technique. So for all the students, what is microarray? A standard karyotype is able to detect only large extra or missing chromosomes, whereas a microarray is able to detect small deletions or duplications also. So it is a slightly advanced technique over the normal karyotype. So what we did is, we gave the parents counseling. De novo mutation was this was a de novo mutation, so the next baby may not necessarily have it. However, we gave them the option of CVS or amniocentesis, but the patient's choice was to not opt for a diagnostic testing, and she was put on a routine antenatal pathway. She's now 37 weeks, 2 days. I'm going to deliver her next week. Okay. So next comes to IVF failure. IVF failure is a very common scenario. Many of us also usually counsel that it could be a matter of chance, because the success of IVF usually does not cross 60 to 65%, even in the best of hands. But you have to slightly look beyond the usual causes also sometimes. So case number 3, Mrs. P, she came at 32 years. normal BMI, male factor. For male factor, she came to us for ICSI procedure for severe male factor infertility. So usual protocol, antagonist protocol was done, 10 eggs were retrieved, 7 were mature oocytes, 2 blastocysts were formed, and we transferred them. So she had a beta HCG of 72. It was a low normal beta HCG. So it's still considered pregnancy positive. However, because it was low, we did a doubling of the beta HCG and it didn't double. So we gave her the diagnosis of biochemical pregnancy. She had no remaining embryos and the patient was upset. So what we can do next? So we counseled the patient to go for another cycle of ICSI, but however, we wanted to rule out all the possible causes of the biochemical pregnancy. So we did the usual battery of tests for RPL, RIF, APLA was done, anti-TG, anti-TPO, everything was done. Ultrasound of the 3D cavity assessment was done. It was all normal. And the female stereotyping showed this particular abnormality. It is a balanced translocation between the 11 and 22nd chromosome. So now, what is a balanced translocation? There is a translocation between the two parts of chromosomes without any loss or gain of any genetic material. In approximately 2 to 5% of the couples with recurrent miscarriages, one of the partners carries a balanced structural chromosomal abnormality. So, if the patient is having, one of the parent is having a balanced translocation, there is a possibility, these are the genetic possibilities that can happen. The baby can be normal, the baby can have a balanced translocation, or the baby can have an unbalanced translocation. So this can lead to the formation of normal embryo in 25%, balanced in 25%, and 50% can lead to unbalanced changes, which may result in implantation failures, miscarriages, and baby with congenital anomalies. So what was the solution given to the lady? So we told the lady, you can opt for a PGT of structural reversal. So PGT was already dealt by the previous speaker in an extensive way. So for this lady, we had advised PGT SR and use the unaffected embryos or use the donor gametes if she doesn't want to undergo the pathway, because there is always a chance that all the embryos can have an abnormality. So the use of donor gametes is not always recommended. However, in Robertsonian translocations involving homologous chromosomes, this can be an option. Case number 4, another case where the male partner had a balanced translocation. So this couple actually underwent an IVF, underwent a PGT-SR with us, and there was in chromosome number 1, it was an in the embryo number 1, it was an unbalanced translocation. Embryo number 2 unbalanced, and embryo number 3 was aneuploid. So we have embryos, but we cannot transfer anything. So again, the patient was in a fix of what to do. So whether it is a dilemma or a good news, patient was asking, after undergoing so much, we have spent so much, still you are telling everything it's actually a good news, because she already had 5 IUI failures, IVF failures with 2 IVF failures. So considering this history, it's a good news that we actually found something for them, and we counsel them for not going for further any cycles of their own and given the option of own eggs with donor sperms. So currently the patient is undergoing the process. Then the next patient is a case of husband is a known case of cryptozoospermia and retinitis pigmentosa. They already had a genetic problem. So they wanted to know what are the chances of the baby having a problem. So straight away we referred them to a genetic counselor, and they did the genetic testing with whole genomic analysis of the husband, wife, husband's father and husband's mother. And we found a homozygous mutation in husband of 2 genes. And the wife was having a normal unaffected state. Only husband's mother and father was a carrier. So it resulted in an autosomal recessive inheritance in their son. So this is how an autosomal recessive inheritance will go. Like all their children will be carriers, but none of them will be affected because the wife is not a carrier. So we advise them to go in for a usual ICSI because of the male factor. There was no need for a specific genetic testing called as the PGT-M. So what is PGT in short? Already it was spoken in the previous talk. PGT-A, whether the test determines the correct number of chromosomes. PGT-M, when you have to select for a specific monogenic disorder. And SR, when chromosomes rearrangement like inversions and translocations are seen. So now we didn't advise PGTM for the couple because the wife was not a carrier. This was another interesting case which came. She was a lawyer, 30-year-old lawyer who came to us for fertility preservation. Although she was married, she wished for oocyte cryopreservation. She was diagnosed with carcinoma breast and planned for chemotherapy. So we should all be happy that she came for a fertility preservation prior to chemotherapy, because after chemotherapy, the eggs are lost. So the histopathology of the carcinoma showed ER/PR positive and HER2 negative. So she was actually genetic analysis. She was sent for genetic analysis. She was done a random stat stimulation protocol. For all the cancer patients, we have to do a random stat stimulation protocol so that we do not waste any further time. Side by side, we did a genetic analysis for the lady, and we have vitrified 18 oocytes. In the pedigree analysis, we see that she was diagnosed with lymphoma. Her maternal grandmother succumbed to bone cancer, and maternal cousin was diagnosed with breast cancer. And 25% of the cases of breast cancer has one of these highly penetrant genes. BRCA1, 2, all of us know, P10, TP53, CDH, and STK11, which can confer up to 80% risk of breast cancer. So in this lady, we actually found the BRCA2 mutation, which is an autosomal dominant condition. That is 50% of her children will be affected. So we have to advise her when she goes for a, we did find a BRCA2 in her. So we have advised her PGTM. After she has found a partner, she can create her embryos, and embryos biopsy should be done, and only the normal embryos should be transferred so that we can avoid any BRCA transmission in her child. Case number 5, she was my friend. She's a 30-year-old lady. She came to me for a counseling because her mother, grandmother, everyone has a family history of breast cancer. So she was very much anxious after having her first daughter, whether she will have breast cancer or not. So we did a genetic analysis, and we found that she had this pathogenic variant of a gene. And we have only thing which we can do is tell that you have a pathogenic variation of a gene. It's very important that you screen yourself. We have referred her to a breast surgeon, and screening has been advised by him as per the protocol. So only thing which I did was just gave a timely intervention. Unless and otherwise we do a genetic test, they will not be very much into the screening pathway. So just referred her and did a watchful expectancy. That's all. Another interesting case which I saw was a 33-year-old lady and 37-year-old man. The male person was diagnosed for a obstructive azoospermia, and the andrologist has diagnosed the agenesis of bilateral vas deferens. So we had planned for ICSI with sperms retrieved through testicular aspiration, but however, according to the ASRM guidelines, the American Society of Reproduction Medicine guidelines, had sent the couple for a genetic counseling, and we identified a CFTR mutation in the male partner, which is a pathogenic variant. So according to the American Urological Association and ASRM, clinicians should recommend cystic fibrosis mutation testing in men with vasal agenesis or idiopathic obstructive azoospermia, and men who harbor a CFTR mutation, genetic evaluation should be recommended. So after we have found the CFTR mutation in the husband, we have recommended genetic screening in the female partner if she also has a mutation of the CFTR gene. So CFTR is a predominantly autosomal recessive inheritance caused by homozygous or compounded heterozygous variants. So in his case, if the wife is also a carrier, then 50% of the children will be carriers, 25% will be affected, and 25% will be unaffected. So it's very important for us to screen the partner when the male partner is affected. So now I'm going to tell 2 stories of hope which has happened because of PGTA. So she was a lady, 30-year-old, who came to us with 3 previous miscarriages, APLA syndrome, lac ACL beta-2 glycoprotein, all 3 were positive. And in her 3rd pregnancy, she had taken low molecular weight heparin and aspirin, which is given for all the ladies with APLA syndrome. Despite that, she had a miscarriage. So someone had correctly done a product of conception karyotype, which showed trisomy 13. And she was counseled elsewhere that only because of APLA, she had miscarriage. When she came to us, we had actually counseled her because 3 miscarriages is a lot of mental trauma. She had undergone 3 DNCs also. So we counseled her for ICSI with PGT so that we can give her the best chances. And also we suggested her aspirin and low molecular weight heparin because she had APLA. So this is the summary of her PGT report. So we biopsied almost 6 embryos. It was her wish to biopsy all her embryos. And first 4 embryos out of them were normal. So I transferred one embryo, only one embryo, euploid embryo, and she has a baby now. So it was because of the PGT, the genetic testing, that we could give her a live birth. Case number 8, 41-year-old lady and 43-year-old partner. They had come to us with secondary infertility for 8 years and had a previous pregnancy that resulted in an anomalous baby. As she was 38 years, we had counseled her for donor egg program, but however, she wanted to try with her own egg, so we respected that, went ahead with a ICSI, but we also advised that PGT because she was already 41, there is an increased risk of aneuploidy. So we got 9 eggs, 6 M2s, that is 6 matured eggs, only one day 5 embryo. Despite that, we went ahead and biopsied that, and the biopsy turned out to be euploid. We transferred that embryo, and she now has a healthy girl baby. So the goal of IVF is actually a healthy single live birth, especially in the cases where indicated, we have to go for a prenatal genetic testing. PGT is a heavily debated topic. We can advise in cases of advanced maternal age, as we had advised, recurrent miscarriages, as we had advised, recurrent implantation failures also we can advise, or severe male factor infertility. People may have different opinions on this, but all these are debated even in the European society. So these are the broad guidelines for which it's advised, not advice for all. So a multidisciplinary approach is essential as far as genetics and OG is concerned, because genetics and reproductive medicine are the evolving branches of ONG. We can make very few changes in obstetrics, so we can only change what happens before obstetrics. The future is when IVF and genetic departments are full-fledged and set up in the government hospitals. So I thank once again my professor, Dr. Meera. This is a photo which we took in our college trip. This was in 2006. So Meera ma'am came with us and I'm standing behind her. So it brought us very fond memories. Thank you. Thank you so much. Thank you, ma'am.
Let me take privilege of inviting Professor Dr. V. Meera Madam, Professor and HOD, Department of Biochemistry, Kilpauk Medical College, for the next session. Here is a brief synopsis of Madam's profile. Madam has graduated MBBS from Madras Medical College, Chennai, DGO from Stanley Medical College, Chennai, Masters in Biochemistry from Madras Medical College, Chennai, Electronic Fetal Monitoring Certificate course from Royal College of Obstetrics and Gynecology, course in Diabetology from American Diabetes Association. Madam's fields of interest, areas of interest include molecular genetics, clinical diagnostics and monitoring using biomolecular markers, molecular oncology. We now invite Madam for the speech.
So in this session, antenatal screening, we are going to discuss how we are going to go on when an antenatal patient approaches us for a safe motherhood. And definitely, I am very proud that as a woman, we stand first to help our womanhood to get up the ladder of adolescent into a woman and then a mother, and with a healthy baby in her hand. So we know how so far we have seen how many new trends, as our previous speakers have talked about. I'm just going to enlighten very few screening and diagnostic tests, which are very important for a safe motherhood. Now, the purpose, what's the purpose of this antenatal screening or antenatal testing? The purpose is to enable timely medical or surgical treatment of a condition on or after birth, and also give the parents a chance to abort a fetus with the diagnosed condition, and also to prepare them psychologically, socially, financially, and medically for a baby with a health problem or disability. So coming to the screening, all women should be offered screening tests regardless of the maternal age or other risk factors, ideally at their first prenatal visit. Whenever a mother or an antenatal patient comes to you, the first thing in your mind, you have to screen the patient. So what are the types of prenatal tests which are available? There are two types of tests. One is screening test, the other is the diagnostic tests. So this prenatal screening test tells the chances that the fetus is going to have a disorder. And the diagnostic test will tell whether the fetus actually has a certain disorder. So this test is usually done on the cells from the fetus or placenta obtained through amniocentesis or chorionic villus sampling. So going to the screening test first. So we saw screening and diagnostic. Now coming to the screening, if you just go through the history of the tests which have been from the first like 1970s, we have a probability graph depending upon the gestational age for detecting trisomy 21 and other aneuploidies. Then in 1980, we were doing some tests like triple tests. And then we had the ultrasonography with the NT or the nuchal translucency. We were able to accurately come to a diagnosis. Then we had the sequential, combined, integrated, and the contingent tests. And finally, by 2020s, we have just entered the molecular level. So first of all, we should have a pre-test counseling. The patient should be counseled on the available prenatal testing options. And they should be explained about the relative advantages and disadvantages of each screening test. And it should be explained to them in detail. And they must be told about the detection rate, how much of positive, false positive rates, and the limitations to be disclosed. Then, finally, after counseling, it is left to the patient whether they are opting for doing the test or rejecting the test for any reason. And how should when you come to the request form, what are the things you have to look into? The test request form must have all these following data: date of collection, the last menstrual period, the ultrasonogram confirmed gestational age, maternal age, relevant pregnancy history, number of fetuses, maternal race, and any information about the diabetic status. So you should look into all these parameters. Then next, coming to multiples of median or MOM. MOM is nothing but multiples of median. This is nothing but a measure of how far an individual test result deviates from the median value of a large set of test results obtained from unaffected pregnancy for each week. For example, if you take a median alpha-fetoprotein value at 16 weeks, normal is 30 nanogram per ml. Now, a patient comes to you, a pregnant patient, whose value is 60 nanogram, then the AFP MOM value is 60, the test value by the standard value. So it is 2. So it is 2 times higher than the normal. This is how you calculate the multiples of median, and this is adjusted according to the variables. Individualized risk of MOM is adjusted to the variables like maternal weight, race, twin pregnancy, and assisted reproductive technology. And you have a formula for the individualized risk. That is, the patient risk is nothing but the prior risk with the age and into likelihood ratio that is calculated from the MOM. That will give you the individual patient risk. Next, coming to the screening report, how you're going to give the report. When you see a screening report, it will be having all these following parameters: the concentration and MOM values of the measured analytes, interpretation as screen positive or negative, Down syndrome or trisomies risk estimate, and recommendations for further action. So coming to the first trimester screening options, you have 3 types of screening options in the first trimester. Combined dual marker screening, enhanced first trimester screening or small EFTS, and non-invasive prenatal screening or NI screening. You just see one by one. So the first one is combined screening. The purpose of this only for aneuploidy. You screen only for aneuploidy. So the markers in this test are free beta human chorionic gonadotrophin, pregnancy associated plasma protein A. This pregnancy PAP A is nothing but an insulin-like growth factor, and it is very, very important for the fetal development. And you have the nuchal translucency. So these are the markers which are necessary. And at what duration will you advise or do this? Actually, from 11 to 13 weeks, you advise for this test. And the sample type is serum, or you have the dried blood sample. The patient can be anywhere. You can get the sample by courier also. And the detection rate is 87.2 and the false positive rate is 5%. So the next is the enhanced first trimester screening. It helps in the STRI disorders, that is fetal aneuploidies. You can see any structural defects you can identify, and you can also know whether the mother is going to go in for preeclampsia. So in this enhanced fetal screening, what is the one which is added? It is the same like previous one, free beta HCG, PAP A. Here you have AFP, alpha fetoprotein, and plasma growth factor. This plasma growth factor again play a vital role. And specifically, it helps, it's a predictor to make whether the patient is going to go in for preeclampsia. And this is done during 11 to 13 weeks gestational age. The serum sample is going to be, the sample type is going to be serum only. Now, when you come to the detection rate, with the nuchal translucency, it is 90% and false positive is 1.4. Whereas without NT, the detection rate is 80 and the false positive is 5. So I'm just showing how important NT plays here. Next, coming to the non-invasive prenatal screening, which is performed prenatally from the cell-free fetal DNA. So it is a non-invasive prenatal screening, and this is done from 10th week onwards, and the sample type is serum. Now we have seen about the first trimester screening. So in that we have seen the enhanced and the markers used. Now coming to the second trimester screening, the optimal screening time frame being 16 to 18 weeks of gestation. So these are the routine tests, triple test, quadruple test, and the non-invasive pregnancy screening, that is SNPs. The triple test is otherwise called the Catering test or the BARTS test. Here you have the maternal serum alpha fetoprotein, unconjugated or unconjugated estriol, and human chorionic gonadotrophin. In the quadruple test, you have an addition of inhibin A, and in NIPS, you have the cell-free fetal DNA. So they screen for open neural tube defects apart from aneuploidy. The first trimester we saw it is mainly for aneuploidy. Here again for open neural tube defect also you can see. So coming to just a chart which is showing triple test. How we are going to assess the risk of Down's trisomy. So in triple test, the 3 parameters are maternal serum alpha fetoprotein and the unconjugated estriol and HCG. Here in Down syndrome, the alpha fetoprotein and unconjugated estriol is reduced and only the HCG is increased. In trisomy 18, all the 3 is reduced. All the 3 markers are reduced. And in neural tube defects, only the alpha fetoprotein is increased and the other 2 are normal. In molar pregnancy, as you all know, beta HCG is going to be very high. The other two parameters are low. And in multiple gestation, the alpha fetoprotein and HCG is more, but the unconjugated estriol is going to be normal. And next chart is the quad test. Here you have some mnemonics. It will be easy for you to remember. So as I've already told you, the added marker is inhibin A and the mnemonic high. High is H is for HCG, I is for inhibin A. So now if it is going to be Down syndrome, the AFP estriol is going to be low and only that high, that is HCG and inhibin A is going to be high. So you have a mnemonic high for Down syndrome. In Turner's, it is very high. That is, the first two, AFP and estriol is decreased and the HCG and inhibin A is very, very high. Next, Edwards syndrome. It is He low. HE is low. What is H? H is HCG and E is estriol. So these two are low and the other two is unchanged. Edwards syndrome. Then Fetal syndrome, it is AF Fetal is high. So the alpha fetoprotein alone is high and all the others are normal. So this is a nice way to remember in a very easy way, mnemonics. Next, coming to the integrated screening, it's a combination of the first trimester combined screen and the second trimester screening. So the results from all the 6 tests, NT, PAPA, AFP, unconjugated estriol, chorionic gonadotrophin and inhibin A, all together, they give a single risk estimate. Then it detects 85% of the Down syndrome with only 1% false positive. And, but its results are not reported until the second trimester. That's a fact here. And this is a graph showing the relative performance of the different tests from the triple test to the integrated. So the integrated test is the best. Coming to the sequential screening, first trimester results are reported to a woman at highest risk. For example, 1 in 25 or higher and are taken for diagnostic testing. And all the others, they proceed for the second trimester collection for integrated approach. In this, 85% detection with 2 to 3% false positive happens. And disadvantages, the NT scan is a must and PAP-A alone is insufficient. So you should be well versed in NT also. Coming to the contingent sequential screening, women are classified as high, low, and intermediate risk based on the first trimester screening. Then the high risk will be recommended for chorionic villus sampling. The low risk will need no other screening. And the intermediate risk will be proceeded with the second trimester screen. Then finally, post-test counseling. So if the screening test is positive, from the conventional serum screening, the patient should be offered non-invasive pregnancy tests and chorionic villus sampling or amniocentesis. So here you can see in this picture, the placental cell DNA and the maternal blood. And you can see some fetal DNA crossing from the placental side to the maternal side. This is nothing but the outermost layer of the placenta is nothing but cytotrophoblast and the syncytiotrophoblast. And from there, the fetal cells are entering the maternal cells. This is how the cell-free fetal DNA is being formed. This cell-free fetal DNA marked the beginning of the non-invasive prenatal testing era, that is NIPT. From where does it originate? It originates from the apoptosis of the cells of the, as I've told you, the outer layer of the placenta, the cyto and the syncytiotrophoblastic cells. And they circulate as very small fragments, less than 200 base pairs DNA. And they are detectable in the maternal sputum as early as 7 weeks gestation and is rapidly cleared after delivery. So the fetal fraction will be around 10 to 20% of the maternal plasma. And it is used for the determination of fetal sex and fetal rhesus D status. And the first commercial screening test for aneuploidy was done in 2011. And it uses the next generation sequencing technologies, for example, like the shotgun sequencing, targeted massive parallel sequencing, analysis of the small nuclear proteins and on chromosomes 21, 18, 13, X and Y chromosomes. So now when to choose this cell-free DNA? When there is an increased risk detected by the combined fetal screening test, or when you have the combined fetal screening test, the patient comes to you in the second trimester, you're not able to, or the third trimester, you're not able to do the first two sessions. So before opting for invasive diagnostic tests, you can opt it. And high-risk patients with previous history of affliction or elderly mothers can be offered this test. What are the advantages of this? It has a much higher detection rate, especially for the trisomy 21 than the traditional serum-based screening, and can significantly reduce the procedure-related losses while maintaining high detection rates. And the screening options are extended to include sex aneuploidies and even whole genome sequencing. So this is how this NIPT blood test, it is almost nearer to amniocentesis in the detection of all this Downs, trisomy 18, 13, sex aneuploidy. So almost 97, 96, 93. And the false positive rate is also less than 0.1. In amniocentesis, it is 0. And risk to pregnancy is 0. In amniocentesis, it is 1 in 200 pregnancy loss. And the failure rate is 5% on the first blood draw. Here it is less than 1 in 1,000. And the turnaround time is 10, whereas in amniocentesis, it is 3 to 14 days. So coming to the disadvantages, it is not recognizing the microdeletions. You cannot recognize microdeletions. So, and it is not also recommended in case of multiple gestations. And placental mosaicism can give false positive results. And patients with low fetal fractions leading to no reportable result have a heightened risk of fetal aneuploidy. So finally, this positive screening results you have invasive and non-invasive. We have seen about the non-invasive, ultrasonography, alpha-fetoprotein, and the screening test and the non-invasive pregnancy test. When it is invasive, you have the chorion villus biopsy and the amniotic fluid and the blood investigations. So the methods of the prenatal diagnosis in case of non-invasive techniques, you visualize the fetal structure and by ultrasonography, fetal echocardiography, and magnetic resonance imaging, MRI. And the invasive techniques, again, by visualizing the fetus, you remove the fetal tissue sampling, cytogenetics, and proceed with molecular genetics. So these are the invasive techniques: chorionic villus sampling, amniocentesis, and fetal blood sampling. Coming to chorionic villus sampling, it is performed between 10 to 13 weeks, and the procedure-related loss is 0.22%. And amniocentesis, it is performed between 15 to 20 weeks, and the procedure-related loss is 0.11%. So the amniotic fluid can be used for estimation of bilirubin level. By estimating the bilirubin level, we can know whether the fetus is going to have any fetal hemolytic disease. Then alpha-fetoprotein, as I told you, for any neural tube defects. Then acetylcholinesterase, again, any open neural tube defect. And cells used for karyotyping for any chromosomal disorders. Here, the fetal cells are cultured for 3 weeks for karyotyping. So this 3 weeks is very long. So as the development of the investigations or the tests, newer techniques like PCR, polymerase chain reaction, fish, they give the result in just 48 hours. So a tremendous shortening of the turnaround time. Then chordosynthesis, we do after 18 weeks. Here the procedure, you have a related loss of 1.4 to 1.9%. And this is a flow chart of cytogenetic analysis. I told you 3 weeks. So here by amniocentesis, you take the amniocyte, culture it over a period of 10 to 14 days. Then the amniocytes are arrested during their metaphase stage of cell division, and the amniocyte harvestation and fixed on slide and stained with dye. Then the chromosomes are examined under microscope. So then only you will be able to give the final karyotyping report. So total time, turnaround time is around 21 days. So you have newer techniques called the rapid aneuploidy test or the RATs. So these are the array of tests. You have the fish. It's nothing but fluorescence in situ hybridization, the quantitative fluorescent polymerase chain reaction, and the multiplex ligation dependent probe amplification. So these are the newer techniques with the rapid turnaround time. So first one is fish. Here, this identifies the targeted region on the chromosomes using specific fluorescent tag DNA probes, thereby enabling the detection of various numerical and structural chromosomal aberrations. And the advantages, the result is available just in 1 day, 24 to 48 hours. The disadvantage, it fails to detect big structural rearrangements. They will identify smaller, but they fail to detect big structural rearrangements. And it identifies 80% clinically relevant abnormalities, and it is very helpful for early decision about further management of the affected pregnancies. So this is how you denature the band of this DNA twine. Then you hybridize with a fluorescent labeled dye. And then, so this is the difference. This is the normal traditional karyotype. And you have the fluorescent fish on the other side. This is 21 days and this is 24 to 48 hours. And next you have the BAX. BAX is nothing but beads, BAX on beads technology. This is a rapid analysis of the aneuploidies and microdeletion syndromes are being detected from amniotic fluid and chorionic villus. So after 10th week of gestation, you can perform this test. It is more or equal, like 99% detection rate is available with this test and 0% false positive rate. Please note, that is wonderful because definitely you will not give a false positive test. What is this BAC? It is nothing but bacterial artificial chromosome. It is being attached to the fluorescently coded beads. And then the genomic DNA is extracted from the test, what you want to find out or analyze. It is extracted, it is labeled, purified. Then you hybridize it to this BAX on beads probes. Then thereafter, the fluorescent signals are measured and the results are analyzed. Next, coming to chromosomal microarray analysis. So I had a patient who was around 31 or 32 years old, and she had Downs, suspected Downs in a scan center here. Then they did amniocentesis. Then again, they were not able to. Then actually, she's from Delhi. So she went there and there they performed fish microarray tests. And finally, they aborted the child to have multiple anomalies, not only Downs. So this chromosomal microarray analysis is a genetic test that can be performed on cells from either the amniocentesis or chorionic villus sample procedure. So this array-based comparative genomic hybridization and a single nucleotide polymorphism array. These two are very important, and they are used for submicroscopic abnormalities. Even by microscopic examination, you can miss. So for submicroscopic abnormalities, you can use this microarray analysis, and it can also detect the conditions found by traditional karyotyping technique also. And they detect tiny bits of extra or missing genetic information. You call it as the copy number variants, or CNVS, that are too small to be detected by traditional karyotypic techniques. So finally, it detects microdeletion syndromes and microduplication syndromes. What is the disadvantage? In spite of finding all these wonderful things, it detects some variants of unknown significance. You call it as VOUS. These are changes in the DNA that may or may not affect the baby's development, but there is no enough data to know for sure. So this is how the reference DNA and the test DNA is being extracted, and they are hybridized, and the signaling are found out. And you can see the signals: red shows loss or deletion, and green shows gain or duplication. Next, assisted reproductive technology. You have many things. I think our speakers will talk about it. You have a pre-implantation genetic screening and diagnosis, where there are some problem with the polar body analysis, blastomere biopsy, trophectoderm biopsy. By doing all this, you can find out whether there is any anomaly or any abnormality, even before the baby gets implanted. Pre-implantation genetic screening. So this uses only a few cells, and errors are possible. Therefore, confirmation of results with chorionic villus sampling or amniocentesis is usually recommended. So this is a flow chart showing how prenatal testing, when a patient comes to you, high risk, you divide into high risk pregnancy, low, medium, and high risk pregnancy. If they are high risk, then you go for non-invasive prenatal screening at the 10th week. If it is negative, you manage according to your clinician's advice. If it is positive, then you go for confirmatory diagnosis with amniocentesis and chorionic villus sampling. And again, low, medium, high, you will be following them from 13 to 30 weeks and 11 to 13 weeks. If it is positive, again, you do NIPS, then the confirmatory test, or you just follow the patient according to the clinician's advice. So no one screening test is superior to the other screening test in all test characteristics. Still more minor microdeletion and epigenetic abnormalities are not detected. Epigenetic is an evolving field in genetics, actually, because epigenetic is nothing but the expression of the DNA is going to differ depending upon the environment. And especially we are just undergoing a great change, especially now. If you see the lifestyle, the food, everything is changing, and there is a change in the epigenetic genome. And until economical and rapid whole exome sequencing is readily available, this is the state of art. So not all of us can do great things, but we can do small things with great love. This is the words of Mother Teresa. So we can do small things with great love. And we all together, because today it is really an integrated CME with all different various departments, we will help a girl to become an adolescent, women, then women entering the womanhood, to deliver a healthy baby, thereby a healthy mother and child, giving a healthy India. Thank you for giving me this opportunity.